morning. So I'll be talking on submacular hemorrhage during vitrectomy from retinal detachment, how to proceed. Now, submacular hemorrhage during vitrectomy from the RD can be because of an inadvertent retinal damage. That can be either from a very senior surgeon who has become overconfident, where you touch the retina, or carelessness. It can happen while peeling a vascular membrane. It can happen during drainage retinotomy, where there can be inadvertent damage to the choroid or an adjacent retinal vessel. It can certainly happen during relaxing retinotomy if you are not very careful, or it could be a choroidal bleed from a laser shot, and I'll show you a case where we had it and how we managed it. The subretinal fluid can also, subretinal bleed can happen when you do external drainage of a scleral buccal, and then you may have to convert, and a subretinal bleed while draining the SP. So without why managing subretinal heme is important. It is because it causes physical separation of the neurosensory retina from the RPE, causing a photoreceptor loss. The heme becomes difficult to mobilize, and that happens pretty rapidly because of clot formation. And this clot can cause photoreceptor traction, and it can happen later on by a clot retraction, or if you are trying to pull the clot off, the photoreceptors may be ripped off while removing the clot, or later on when there is hemosiderin formation, which can cause the heme is toxic to the photoreceptors, and then you can have subretinal fibrosis. Now, generally, whenever it happens, how do we manage them? There are certain general measures which we take, and there are specific measures which we take in different situations. Please do not overlook any bleeding, because any bleeding can go subretinal if there is an associated break or a drainage retinotomy. You must manage the blood pressure and the heart rate, so you have to have a good anesthetic support. You should increase the infusion pressure when required, inject PFCL, or you can even mechanically block the bleeder, and if required, you can actually switch to air. You can add thrombin to the infusion, which I have not personally done, but there are adequate studies available which show that thrombin could be useful. And as many years back, which we don't do now, we were used to add adrenaline to the infusion. Now, other than that, let us see how these situations are. If you have taken adequate preventive measures, like in this particular case, where the BP and heart rate were well controlled, we had pre-treated the patient with an anti-VEGF. In this case, this is a very fibrovascular membrane. Now you will see that I am doing proportionate reflux. You can see those fluid coming out. We create a path which we have identified the place where we have to dissect these membranes, and once we dissect them out, if there is a hemorrhage on the retinal surface, it's better to mop it off rapidly, remove it before it forms a membrane. So in case you have a simultaneous chandelier illumination on, then this can also be done in a bimanual manner. So there's a study which has shown that intravitreal thrombin helps in controlling vitreous hemorrhage, but some of these cases do develop inflammation. I have personally not used, but I think this could be a useful tool in hands, and maybe somebody in the panel has been using it and will get their feedback on this. So I'll show you some cases. So there was a large subretinal bleed. PFCL has been injected. Once we inject the PFCL, it's a large bleed, therefore we create a large peripheral retinotomy. We can either do it with a hard tip, soft tip, or a snake, which goes through the peripheral retinotomy, and that clot is removed, or sometimes we have to use an end gripping forceps for removal of the heme, and this is followed by fluid air exchange, silicone oil injection, or a fluid gas exchange, and it does well. Another patient who had a large bleed submacularly, the blood has been displaced by PFCL injection just above the disc. Our drainage retinotomy has been created, and this heme is then removed so that the macula is protected. So it's very important that we are freely using perfluorocarbon liquid when required. Whenever the bleeding is not getting controlled and we have taken all measures, you can always switch to air, increase the infusion pressure, close all the ports, and make sure that the bleeding is stopped, and go back again. So this is an example of a blood being removed from just above the disc in a subretinal space, and this is followed by standard technique followed by fluid gas exchange, and the macula has been saved, the patient as well. This is a video which I borrowed from Dr. Subhendu, who had a massive bleed subretinally. He went ahead and did a relaxing retinotomy. First cleared the vitreous hemorrhage, and then completed the vitrectomy, went in, did a relaxing retinotomy, injected PFCL. You can see him going in the subretinal space, picking up the blood clot and removing. Now, how many photoreceptors got damaged, we don't know, but yes, he was able to remove the entire blood clot adequately. The macula is clear. The retina at the end, you will see, settles fairly well. I'll just speed it up a little bit, and so this is how it looks like in the end. This has been lasered. This is another patient whom we had submacular hemorrhage. This was a patient with a retinal detachment where a standard procedure was done, had multiple breaks in the periphery. You can see those multiple horseshoe tears, and a vitrectomy was done. The case was going fairly well. After having completed the vitrectomy, we did a fluid air exchange. And this was followed by, under the fluid exchange, under the air, we did a laser, and this laser was topped up after silicone oil injection. And while I was doing this laser under silicone oil, there was a bleed, subretinal bleed from the edge of the break. Now, it was very important that since the blood was subretinal, it was a silicone-filled eye. I had to make sure that the blood doesn't travel to the macular area. So PFCL was injected over the macula in a silicone-filled eye. We tried to ensure that once we have the hemorrhage restricted above the arcades, it doesn't go submacularly. The endolaser was completed. Whatever blood we could remove from that area was removed. And we had a very thin film of blood in the end. Then the PFCL was removed, silicone oil exchange done, and there was a standard closure of the retina. This is how the patient looked like post-operatively, which the macula looks fairly clear. The patient's visual acuity had improved to 612 1 week post-operatively, and he is doing fairly well. Now, here I am going to present a relatively new method of an improvisation which I have done. This was a 63 years old male diabetic, poorly controlled. VIA surgery had been done in both eyes. Patient best corrected visual acuity was 6/24 in the right eye. The left eye was inaccurate. So we decided to do a silicone oil removal, extensive membrane surgery, subretinal TPA injection, and removal of subretinal heme with a silicone oil exchange. So this is how patient looked like. This was last year he had presented to us. So I'm sharing with you a device. Can you increase the volume? So this is a new one which we have made. This is a very the device has now been modified further, where the tuberculin syringe. So this was available by Med1, but it was not available at that time in India. So we made this device which couples a 10 cc syringe with a 2 cc syringe, and this is connected to the Constellation infusion, the silicone oil injection system, where the pressure is generally kept at about 8 millimeters of mercury. And when this pressure is on, we prime the tuberculin syringe, where you can see the TPA coming out, and this makes it extremely well controlled. This device, we are we have now almost perfected it, which could be used for subretinal injection in gene therapy. You can see the change in color. There's an orange color hue you get. We have gone subretinal, injected the TPA. This was injected at 2 places. This actually had a good sound. I don't know why the sound is not coming. Anyway, this was injected at 2-3 places, and having completed that, we did a silicone oil exchange. The eye was kept a little underfill, and this is the post-operative follow-up of this patient. The retina is quite ischemic in the macular area. All the membranes have been cleared from the disc. The heme has moved from the macula subretinally. So that is a way we can do these cases. Another thing which I wish to introduce is fibrin glue assisted hemostasis for persistent intraoperative optic nerve bleeding. And this is a case which has been shared by Dr. Mudit, which has been recently published. He got an award also for this particular methodology, and this is his small little video which I'll share with you of how he uses fibrin glue. And I think this will be path breaking in cases of where we have breaks which which we can put a fibrin glue, don't use a fluid gas exchange, don't use silicone oil, no tamponade, and we are able to settle the retina just by using a fibrin glue. So let me just, so here the fibrin glue will be injected over the macular area or over the optic disc area where there was a bleed. You can see the bleed there. Most of the blood is removed. The bleed was persistent. So this injection is being done now. So, and later on, once the bleeding has stopped, this membrane is just folded over the optic nerve head. A very intelligent way of handling an optic nerve bleed, which we find always difficult how to handle, and this patient did well. So take-home points are good systemic control, pre-op anti-VEGF injections, address any bleeding during vitrectomy immediately, avoid subretinal migration or membrane formation, liberal use of perfluorocarbon liquid, infusion pressure elevation, may need to close ports and wait, can switch to air if required, judicious use of thermocautery, simultaneous aspiration with the thermocautery, so you have to have a bimanual system. And I have not used the fibrin glue, but yes, that could be a wonderful tool in a hand. Always do not panic, just sit back and see what you can do. In severe cases, one can always go back on another day and intervene. We have done it in the past, though it becomes difficult because membranes forms. And thank you very much, and thank you, Bhuvan, for this opportunity.
Thank you, Dr. Ajay. Very nice presentation. Although your topic was submacular hemorrhage during vitrectomy, you discussed all types of hemorrhages and how to control them. So I think the main purpose was if we have a complication during a surgery, intraoperative, the thing is you should not panic. And I think Dr. Ajay has highlighted all the main things, what to do if you develop a submacular hemorrhage during a vitrectomy. Thank you, sir. Any questions from the audience?
Occurs either when you're putting the suture or it occurs when you're doing the drainage. The first thing is don't drain it. If you don't drain it, the blood remains fluid, and if you put the patient into a sitting position, it will settle down. If it's a very large bleed, of course you have no choice but to go in and clean it up. But if it's a small bleed, it will generally go into an extrafoveal location. The mistake people make is that they will drain it. Once it's drained dry, it will become a clot, and that clot will settle on the fovea.
Can I make a comment? So increasingly we have new technology. I think Alcon is about to release the Unity, and we have other newer vitrectomy machines that can control pressure in the eye. So if you get a bleed like this, what would be your best way of raising the pressure to control the bleed really predictably?
So we normally, in our system, we can increase the pressure to 60 immediately by the foot control method. The Constellation has a system, we increase it to 60 with just a tap of a switch and it goes up. And one could actually use different instruments, which can be like even an, blunt-ended, like a Thanos scraper, which is not diamond dusted, but it's old, that can be pressed over the bleed and it can stop. or even the end point of a cutter, because these are beveled now, that can stop.
So you raise the pressure to 60, and that might also be automated. So you just make one button, goes up to 60, and then when do you bring it down?
So that is the trick.
That's the trick.
That is the trick. So I think what we normally do is we raise the pressure, wait for the time, we consider the normal bleeding time. I, in my mind, count from 1 to 120 or 130, and I take the reservoir, go back and see if the blood has stopped. I just keep the pressure high, just see if the looks like the clot has formed, then I gradually bring it down and take a decision.
So I have to make a comment. See, this is not like a diabetic bleeding. This is a submacular hemorrhage which is happening. So you can't leave the ports. I think you have to increase the pressure, but you have to be very careful that the blood does not seep underneath the macula. So the most important thing here is that we should prevent the bleed to reach the macula.
Yes.
So I think immediately what you should try to do is raise the bottle height, increase the pressure and put PFCL so that the blood stays away from the macula. And if you have a clot, like you showed in one of your videos, which is away from the macula, we can even leave a small clot. But if the blood is underneath the macula, then you have to remove it by methods which you have shown, either by displace it by PFCL and then drain it, or create a large, you have to create a large retinotomy temporally, like a GRT, and then lift the flap and remove the blood. So the most important thing is, I think you have to act fast. You have to increase the pressure, and you have to put PFCL, and probably then locate the bleeder and probably try to close it with a diathermize it. And once you're sure that the bleeding has stopped, that is the time you should try to reduce the pressure and see whether it is rebleeding or not.
So the case which I showed you, the initial surgery had a bleed. We almost did a PFCL siliconal exchange.
Yeah.
Do you think that the gauge is important now? You know, we're headed now to doing 27 gauge, and I think we will see this in the next 1 to 2 years. We'll probably move that way. Do you think we'll have less of these problems, or we can manage them better?
So I think that's very true. See, the problems we face in India is reuse of our instruments. So when we have 27 gauge, it's very difficult to reuse them. So most of us use 25 gauge, and I agree that when you have a smaller gauge, you will be able to do a better tissue dissection. You can stay away from the blood vessels, you can save on blood vessels. So maybe in such a case, we'll follow a hybrid approach where we have the cutter going through 27 gauge and rest of it could be 25, or I could just stick to 25 and be happy with whatever I'm doing.
Great talk, Ajay. So my question is that when will you not feel bothersome to stop the bleeding? For example, in your case, the bleeding is coming up from the inferior part for the laser. After that, it's seeping toward the macula. But you know that, I mean, after this surgery, you have the patient have a prone position to displace the blood from the macula. So when will you look at that kind of case and you say, well, I'm not worried about this, and I have the patient have a tamponade and then coming without any intervention further?
Yeah, so that's what I did in that case. So when the active bleeding is there, I have to ensure two things. One, the bleeding, the heme does not reach the submacular area. So therefore, I have a PFCL bubble that prevents the blood from reaching the submacular area. Once it has got clotted, I'm a bit more relaxed that it is not going to move forward, and there is no active bleeding occurring at the point where it was occurring earlier. Then I can do a siliconal exchange. I can put in siliconal exchange and post-operatively ask the patient to be on a prone positioning, and that works well.
Okay.
We'll move to our next